Hello, everyone. Welcome to August's Data Committee meeting. This is for the epidemiologists of all of our different member jurisdictions, which you all know. I'm so excited you're here joining us today. We have Hannah Brosnan of the San Francisco Department of Public Health speaking on their case and contact investigation in San Francisco for COVID-19. So we'll start that in just a few minutes. But first, why don't we go ahead and do introductions? So it would be wonderful if you could let us know your name and what department you're from, and any other notes or details you'd like to provide. We're happy to hear from your position to what brings you here today. Anything along those lines, we'd love to hear it. So let's go ahead and get started.
I'm Matt Byers. I'm a supervising epidemiologist in Alameda County.
Welcome, Matt.
I'm Billy Leung, and I'm an HIV epidemiologist at Alameda County.
I'm Melody. I also work with Billy at Alameda County. I am an HIV epidemiologist.
Welcome, you two. It's great to have you here.
This is Danny Allgaier, the last HIV epidemiologist for Alameda County.
Hello there, this is Melissa from BARHII.
I can see more of you on the line, so I'll start calling on people if you don't announce yourself. We'll have to welcome each of you personally.
Oh, good afternoon, everyone. It's Mylene.
Hi, Mylene.
Hi, everyone.
From Solano.
Hi, everyone. I'm Alex Ernst from UCSF, working very closely with SFDPH to do contact tracing. Sorry, I joined a few minutes late, but I gathered we're doing introductions. Nice to meet everyone.
Hi, I'm Hillary Spindler, also from UCSF, working with SFDPH.
Hi, this is Araceli Tamayo from San Mateo County.
Hi there, this is Shamsi Sultani, San Francisco DPH epidemiologist.
Thanks for joining us.
Hi, this is Maddie Sankaran, also an epidemiologist from SFDPH.
Great.
Looks like Jessica and Contra Costa might be having a challenge with her audio.
Yeah. Nice to have you, Jessica. Sorry about your mic.
This is Meredith Millett from CDPH. Sorry, I missed it. You go ahead.
Okay, this is Debbie Vanels from San Mateo County.
Meredith Millett from the California Department of Public Health, Office of Health Equity.
Hi, Debbie and Meredith. Thanks for joining us today. I see one or two others. Anyone else for introductions before we go ahead and get started?
Hi, this is Jessica Cunningham-Kroll. I got my audio fixed from Contra Costa. Hi.
Great. Thanks for joining us, Jessica.
Looks like we have Madeline and Melody. Melody. I don't know if you've introduced yourselves.
Melody definitely said hi.
Oh, okay.
But Madeline?
Madeline was Maddie.
Oh, sorry.
Well, great. Welcome, everyone. So glad to have you here. We're going to go ahead and get started. Like I said previously, we have Hannah Brosnan from San Francisco Department of Public Health. Sounds like she brought a bunch of her team members as well. So thanks, San Francisco, for joining us today. And Hannah, you should have full control. So go ahead and take it away when you're ready.
Okay, great. Thank you so much. And thank you to my teammates for jumping in. I'm really excited that a lot of you were able to make it, and please do feel free to chime in. So my name is Hannah Brosnan. I'm an epidemiologist in San Francisco. Pre-COVID STD epidemiologist, some HIV work as well. So it sounds like we all have a lot in common. I'm very excited to share some of what we've been up to with this group. From what Meg Wall and Michelle Kirian have told me, who are regular attendees of this group, that this is just a wonderful place to share ideas, get feedback, and just really hear what other people are doing. So that, you know, made me really excited to come here and excited to share with you and get this opportunity. So as I'm going along, I know Zoom can be a little awkward sometimes for chiming in, or I'll have the chat up here too, so I'll try and be monitoring that if you want to ask questions that way. But no need to hold anything till the end or anything like that. Do feel free to chime in whenever you like. Okay, so I had, let's make sure it keeps going. Here we go. So I had started with a little poll. I've seen people do this successfully. I have not yet, so we'll see how it goes. The first question was already answered in the introductions. I just wanted to get a sense of what counties people are coming from. So if you'd like to test it out and type it in the chat, that's great. So I can remember when you're asking your questions, what county you're coming from. And you can interpret that. It may be the county you work, it may be the county you're from. My county is San Francisco, and that's actually where I grew up as well. So it's my answer for both. Thank you, Jessica. I do see your chat that it says Contra Costa, even though your audio is not working. Great. Thank you, everyone, for doing the chat. And then the next question I had was, how much of your working time is spent on your county's COVID-19 response? And in a true epi group, I had originally asked what % of your time, but I realized that might not give me the answer I wanted, because maybe people are doing, you know, 2-week deployments or things like that. So I rephrased my question to be more qualitative. And as you're answering, okay, Matt says 65%. I like that. Yeah, I would say, you know, 1 or 2 week deployments every month or two from Meredith. Alex, 85%. I think that probably equates to like 200% from what I know about your working schedule, but just adding you. Shamsi, about 60%. Mylene, 125%. That sounds honest and true. Debbie says over 95%. Oh, and live in King County. Okay, cool. And then Maddie, double SF, and 80% COVID. Okay, so a lot of time and a lot of expertise in this room on COVID responses in different counties. So it should be a really good discussion. And Jessica says nearly, 100% on COVID. Next question is, and last question for polling, is what data system does your county use for case and contact investigations, if any, and if you know? Do you use CalConnect? Do you use something else? Mylene says CalConnect. I see another CalConnect from Jessica. Anyone using anything else? San Mateo uses RedCap. Okay, great. Okay, so for the rest of the discussion today, my plan is to hopefully have a lot of back and forth and conversation as we go through, but I'll give a brief review of some San Francisco epidemiology of our COVID epidemic and our key indicators that were developed with the Bay Area wide group and our kind of status on those. And my idea, those are all from our public facing dashboards that we have in San Francisco. So there's no, you know, new information, but hopefully they'll help us facilitate a conversation about some of the underlying processes that go into producing them and putting them on our public facing dashboards. And then after that, I'll go into a little bit more depth about how we're conducting our case and contact investigations and managing and reporting our data in San Francisco. And then lastly, you know, how are we doing on our case and contact investigations and where do we want to go from here? So with that, I'll dive in. So this curve probably looks familiar, and it looks pretty similar in a lot of the counties from what I know that are represented on this call and in the Bay Area, where you can see, from our initial cases, we kind of had, our slow up creep in our cumulative case count. And then around the beginning of July, started to see sharper increases. But kind of in contrast, our deaths from COVID-19, which any are too many, but we saw more of our deaths earlier in the epidemic. And we still see people dying from COVID-19, but not at the same rate as in the early days of the epidemic. And so this is the chart that we, kind of like the first chart that we started sharing publicly on our Data SF portal and updating daily for the public to view. And so that, was something, at least in communicable disease in the San Francisco Department of Public Health, that we hadn't really done before, these daily updates on surveillance-based data. So it was a big challenge to us to respond to questions about like yesterday this number said 53 cases on this date, and then the next day it said 52. And in our mind that's like, oh, of course that's we found out this person, it's not in our jurisdiction or something like that. But it was just a real steep learning curve about what kind of questions can we anticipate from the public. And back in my STD days, I would have been so excited if someone noticed a data discrepancy on one of our reports. But it's definitely a different type of communication with the public that I certainly was used to in a lot of our teams. And then we also still have our disclaimers up on our data trackers on the website about statewide reporting issues. And as we continue to reconcile our lab reporting data with the state and work together to figure out, are we really getting all the reports, and continue to QA those processes. So also wondering, are other counties doing the same, and how's that going for you? So feel free to chime in, and I'll just keep going until I hear people interrupt. And then so a little bit later, we realized that it would be really helpful to have the cases, new cases per day. And so here we have a 7-day average of cases per day that we've been presenting. And I'm sure these curves also look familiar to a lot of people on this call. And you can see the, bigger increases starting in July. And so this page was also up pretty early on for San Francisco. And, we added categories as we became confident that we could share the data. As many of you know, we've been seeing a huge disparity in our COVID-19 cases in San Francisco, with our Hispanic and Latino community disproportionately affected by COVID-19. And this has, big implications for our case and contact investigation, as well as many of our cases are Spanish speaking. And so we've been working really hard to match our workforce to the cases that we're serving. So that's been really important for us to know and be able to respond to. And then another challenge that we've been grappling with around age and race and other stratifications is really being only able to present these in their 2x2 form and not being able to present additional stratifications by race and age, for example, because those cell counts just get too small, and we risk, violating the privacy of our cases. So that's been, we want to be, again, balancing that transparency and protecting the privacy of patients in San Francisco. Similarly, so if you're on the website, you can actually just toggle between cases and deaths. And so as we saw in the curves, our deaths in San Francisco were occurring a little bit earlier in the epidemic. And so we actually see a pretty different breakdown in the race and age of our deaths from COVID-19 compared with our cases. And those who have passed away were more likely to be 81 or over, and Asian race ethnicity. And then here we have our maps and our map, I should say. It actually, if you're on the website as well, you can zoom in. This is just a screen grab for the presentation, but you can zoom in and go down to more granular levels on the map. But this recently changed. We had originally had set buckets for our case ranges for the different variation. And then as our time progressed, it kind of just turned out most of our map was, a dark blue because many regions had surpassed that threshold level that we had earlier set. So I think it was just this week that we were able to change it to these dynamic ramp levels so that you can more clearly see where the disparities are in San Francisco in terms of case count. And so you can see that the cases per 100,000 residents are highest in the southeastern neighborhoods of San Francisco, especially Bayview, Hunters Point, and the Tenderloin. It's kind of striking to me as well. And as I know, this group is hugely focused on the social determinants of health. Like, it would be very easy to take this map and overlay our STD map from our annual report. And you can just so clearly see how the social determinants of health are really driving this epidemic. Now, switching gears a little bit. So these are our key indicators, which were, as I understand, chosen in consultation by a group of Bay Area health officers to have 5 categories on the hospital system, cases, testing, contact tracing, and personal protective equipment. And I'm sure many of you are even more familiar with these than I am, but the idea is that these are take what information we have and set some standards for red, yellow, and green for each of these areas. And then policymakers can take all of this information together in order to kind of like push and pull the levers of reopening to slow things down, or say, green, we're clear to go. And so these are data through 8/15, but for the rate of weekly change in COVID hospitalizations, there's a few metrics on hospitalizations. I just picked this one. We're green. We're meeting our target at 8%. But you can see, not too long ago, we were up in the red over here. Our case rates at over, I think it's, so here we want our level to be less than 1.8, but we've been consistently above that for some time now. So we've been, calling it our surge and responding in that way. So our tests collected per day, like many other counties, has remained very high since early days, which is good. Of course, there are many caveats to that in terms of who has access to a test, what are the turnaround times for testing, and how do we, how do we look at this measure more closely to, not just see green and actually use it for better information to change our policies. And then this one is about the personal protective equipment with 30-day supply. So they have 9 categories, and they put those together to say what % of those categories have at least a 30-day supply, and that's been pretty consistently in the yellow. And so the last one that I didn't mention yet is about the contact tracing. So I will go into a little more depth about the background of the contact tracing data before I share the metric. For anyone who's, just can't wait, of course, you could just go on the data SF tracker and look it up yourself if you really wanted to. I'm not seeing any questions in the chat, but do feel free to chime in or comment or, say, my county does it differently whenever you like, and I'll try and keep an eye on it. Okay, so for the case and contact investigations, it's kind of like some things have stayed pretty consistent over the whole response in San Francisco, that we want to have, wraparound support for cases and their contacts, both to help the cases avoid more severe outcomes of the disease, as well as intervene on disease transmission by reaching out to the contacts and facilitating isolation, quarantine, and now testing. That was a change throughout the process. And so what does that kind of look like in San Francisco? It has changed over time. Right now we have most of our case and contact investigators either working remotely from home, or we have our Moscone Center, command center, where people rotate in and out. We're using Teams chats, we're having huddles on Teams. We sometimes have a buddy system where two people remotely will, act as if they share an office, essentially, to share tips and tricks and things like that. And one of the highlights really is like an all teams meeting on Friday afternoons where all the case and contact investigators meet together, which is led by Jess Celentano from UCSF, and really is a reflective moment. It's been super inspirational to hear the stories and stay upbeat in this really, really challenging work. And so the general flow is that almost all the cases we get, we intend to, did that go black for everybody? Sorry, I should be back if you couldn't see my screen. So all the cases we get, we intend to reach out to for case investigation. And then a small proportion are followed by the outbreak management group, and that's really cases from skilled nursing facilities, long-term care facilities, and such places where it's more of a contained living situation or a congregate living situation where the strategy is quite different. So those small proportion we try to redirect to a more appropriate team, but the majority are assigned for case investigation. And then after the case investigator elicits the contacts, those are followed up for tracing and monitoring. So this very fancy timeline here, I broke up the kind of timeline from our first cases in San Francisco, our first two cases on March 5th up till the present. And so actually I'm really excited that Alex, Hillary, Chomsky, and Maddie are here because they might break it into different buckets. So you can hear if you might describe it differently. So actually I'm gonna put like a fake bucket right before this one, where we first had an emergency declared in San Francisco, and our response was really traveler follow-up. So we had a database of returned travelers and following them up for symptoms monitoring and quarantine when they got back. And that was all set up in an access database in San Francisco and monitored by, what then felt like a robust and big team, but really in contrast is quite small. And then, when we got when our first cases were identified in San Francisco, I kind of chunked March 5th to April 15th as our real kind of like ramp up period for our response. We quickly switched to doing full case investigations on paper forms. I have a pretty vivid memory of the case forms hanging on in a folder on the wall, and then the folder, it was kind of a very stark moment when the folder fell off the wall because it was too heavy. We just couldn't keep up with the data entry of the paper forms at that time. And I reflect on this and think we're really lucky that our leadership really said, okay, we need to make a change, and formalize a partnership with UCSF to, build a huge team to be able to do our contact tracing. So that kind of also meant that we have this huge team now working in so many different places and on so many different systems. And that's what led to the decision to switch over to ComCare for our for case investigation and contact tracing, which is our case investigation data collection tool, which is web-based. And so that we did, and I could also put another bucket in here. I'm looking at Alex right now and thinking Qualtrics. We had, interim systems in Qualtrics to collect data and go from there. So small caveat there. And then I cut this bucket off at March 5th because that's when we recommended testing for all of the contacts. So before that, we had been, doing symptom screening and recommendation of testing for high risk contacts. But around March 5th, we started recommending that all contacts get tested. And so from March 5th to the beginning of July, we really, we continued to develop CommCare and have it really customized, and we're making changes to it every week as we, identify needs for follow-up for people. Our systems really beefed up at this point. I broke it off here at around July 1st. It's a little rough, but that's when we really started seeing the increase in cases. And I just think of that as the first time we have these, folders of cases waiting to be assigned for case investigation. And this was the first time we couldn't get through all the cases that were waiting in a day. So I was just so impressed with the way our teams really dove into figuring out a way to prioritize cases for case investigation. We quickly realized that, going from the one that had been sitting there the longest until it was followed up actually was not allowing us to intervene on disease transmission as efficiently, because that person, their specimen would have been collected, a few days even before that, before they got the result and things like that. So the opportunity to elicit their contacts and get those people quarantined had kind of passed. So we had to shift gears a lot. And we also used the other information we're collecting, like the person's zip code and their age, to prioritize cases. So we knew where, based on all this mapping we have been doing and monitoring, where the areas of San Francisco with the highest disease transmission were. So we were able to use those zip codes to prioritize cases when we knew we couldn't get to all of them in a day, while at the same time we're building up our teams and building up our capacity to be able to respond. So that's kind of a saga in just a few months, but it's been, at times it's both difficult and just like, I'm just so impressed by everyone that I work with. And then this, another fancy diagram here, just goes into a little more depth about the flow of data in San Francisco. So we get our electronic lab reporting and, provider reports, whether they're faxed in or emailed or anything like that. And we also have a couple independent lab streams, like from our public health lab in San Francisco, from the San Francisco General Lab, which, kind of, some are duplicated, but all kind of like help us monitor where there's a problem in one or the other. And so all of those flow into our in-house database on the SQL server. And in there we do, some processing and deduplication and things like that. And then we have, this back and forth data flow between our SQL Server database and our CommCare system, which I briefly spoke about before for our case investigation and data collection tool. And so this gets into a little bit, I guess, hold on, let me pause here actually, if anybody has any questions or comments on kind of like the process for case and contact investigation, especially around the data flows or data collection, or anything to add from my team members on the call. Great, I explained everything.
This is Jessica from Contra Costa. Can I ask a quick question?
Yes,
so
please.
where does where does CalReady play into the diagram you just showed? Like, are you entering anything into CalReady, or are you only using ComCare and then transmitting to the state like as a separate file, or how's that all working?
You're right. There should be another box for CalReady up here because we do report in CalReady. And so how it works right now is that we do all our investigation in ComCare, and then we have a team who takes that data from ComCare and translates it to a report to go into CalReady. And so we also do monitor CalReady cases coming in kind of on this side of the data flow, and mostly make sure that everything is matching up and that we can account for all the cases coming in.
And Hannah, just really quickly, if you do know, in what form is the information from ComCare being sent to CalReady?
Actually, if my colleagues are still on the phone, they might know, but I believe that we generate reports from ComCare and then they're manually entered into CalReady. There's no bulk.
Okay, there's no like CSV or something like that you can just send to them. All
I'm
right.
pretty sure I can verify that, but I don't think so. Maddie verifies, yes, they're manually entered. Thank you, Maddie. Okay, so how are we doing? So our two metrics that we have on the key indicators dashboard, the first one's for cases. And so we've been monitoring the % of cases reached over the prior 2 weeks. And so these are cases that we've had a successful interview with, and they've agreed to participate in the case investigation. And so it's kind of, you can see we've had some dips and things like that. So like this first dip I know well is when we had a problem with our lab reporting and we had a delay in the report of cases. So we had, older cases coming in, and we had to close them out without reaching them because they were too old and we had too high of a volume. And so then here, we're not limiting the denominator to those we've attempted. It's all cases assigned for case investigation. And this if you go on the tracker as well, you can scroll all the way back to, I believe it's April 15th or April 13th, which as you'll remember from that timeline is really when we started doing the investigations in ComCare and what we consider our standard process. So when we had lower case counts, we were really, pretty consistently above 80% who had successful interviews, and which is, pretty different than my work in STD. We are not consistently reaching that many of our San Franciscans diagnosed with syphilis and HIV, but we are here for COVID, so that's quite a contrast. And then in terms of challenges, like you'll see here we have contact tracing data set coming soon. Many of our dashboards have underlying data sets that you can download. But we haven't yet had stable enough data. We're constantly doing QA and things like that to be able to put that out and know that, even though we're confident that our metric is accurate to indicate our situation, but that our underlying numbers won't be shifting in a way that would invite more questions than would be productive for our team. But I mean, there's, a lot of back and forth on that, and a lot of people have different opinions about it. And then similarly for contacts, we are tracking the % of contacts reached over the prior 2 weeks. So that's the 14-day average displayed up here with, and I forgot to mention this on the last one, where we update these weekly with a 4-day delay to allow time for the data to stabilize and as well as time for reaching out. So, you know, similarly, when we had less cases, we're able to get consistently to most of the contacts. And then as cases have increased, that has declined a bit, but has stayed pretty high. You know, and contacts come in with a wide variety of completeness of information and phone numbers and things like that. These are deduplicated as well as limited to those who are not already positive at the time the contact was identified. So if there's members of a household where more than one person is positive, even though the person is a contact to the case, we don't include them in this denominator for contacts reached, because these are the ones we want to reach to recommend testing and quarantine or isolation. Any questions on that or variation? Oh, I should say that here, sorry if I already mentioned this, but in slight contrast to what we measure for the cases, for contacts, we're measuring those who were notified of their exposure to COVID-19. So the idea is that, you know, even if someone does refuse to isolate or quarantine, we know that they got the information and they got the recommendation. And so we're working on some additional metrics to, you know, provide more context to that, but that was the measure we agreed on. Anyone doing it differently? How many contacts do you get per case? So right now our median is 2. And that can vary pretty widely. What we do see a lot is larger households where, like the situation I described, where there will already be more than one case in the household when the first case is identified. So that number, the median 2, doesn't account for those cases that were already diagnosed in the household. And the majority of our contacts that we get are household contacts. Yeah, similar in Santa Clara County, but doesn't seem real. Yeah, it is. And I think partially that too, and maybe Alex can speak to this, is our definition for contacts is someone, it's changed from 10 minutes to 15 minutes, but someone that you were in close contact with for 15 minutes or more. So I think it's a challenging question for people too, and I know our case investigators and contact tracers are really skilled at helping people identify that, but I think it is hard to identify everyone, you know, you may have been in contact with.
Hannah, and this is actually open to everyone too on the call. For identifying close contacts, so we identify, this is Mylene with Solana, by the way, and so we consider close contacts as anyone, of course, like the CDC definition of 15 minutes within 6 feet, but then if they are both masked, we're actually not considering them as close contacts. Do you guys, do you differentiate between those, or anyone really within 6 feet and 15 minutes is considered close contact regardless of any masking?
Alex,
can you chime in on the masking?
Yeah, no problem. So it was something that was taken up by our policy group, and they actually decided that, like, regardless of masking, that if they've been within 6 feet for more than 15 minutes, that they would be considered a close contact. And I think a lot of that, like, hesitation of do we think about masking versus not masking is just people's adherence to effective masking is kind of mixed. And when you think about, like, somebody who may have been exposed at multiple points, if you're only asking about masking at the last exposure, well, what if they were with that person, for example, the day before their last exposure unmasked or something like that? So there was, I think, a lot of questions that came up for us in the policy group about masking. And so we opted to elicit them regardless. And just to add to what Hannah said, that not only those that meet the CDC guidelines are considered close contacts, but also anyone who's a household member, which is obviously why, because they're sharing kitchens and bathrooms and things like that, which is possibly why we're seeing a lot more household contacts as well, in addition to intimate or sexual partners and anyone who's exchanged or had, bodily fluids, been exposed to bodily fluids. So there's a few like less common examples, but those are certainly people that we'd want to elicit as well.
Right, thank you. And how about other counties? I just like to hear what others are doing, because for us, I mean, that's just thinking of it as really a droplet precaution, as a droplet transmission, right? If you're both masked, unless the other person is really hacking away, then there's a possibility. But with two people masking, that's why you're able to have activities, even though yes, we say with you have to keep 6 feet, but if you can't do that 6 feet, you at least have to be masked, especially if they're both wearing surgical masks. So I think sometimes we do need to, these are the things that we have to take into consideration when we're creating these policies, because especially if you're going to then quarantine exposed people, the ramifications of quarantine for 14 days, especially those who are not getting paid and they're the sole person who's making money for that. So, do your kids go hungry, or do you, I think there are certain ramifications to all the decisions that we make. Yes, as public health, we do have to think of the, sorry, I'm just kind of, I think for us, this is kind of one of my pet peeves, is the decisions that we do sometimes make in public health. Yes, as public health, we protect, our main thing is to protect the health of the public, but part of the health is also, financial health and financial stability. So it's just things that we do need to consider when we're making these decisions.
Yeah, I'll just add I think that, in San Francisco, we're in a really lucky position where we're able to offer our close contacts, certain social service benefits for staying in quarantine and going through the contact tracing interview with us, that, we do have the Right to Recover program in San Francisco for cases to provide them financial assistance. But even for contacts, we are able to provide them like food supply for 14 days, cleaning materials, link them to housing if they need to be more stably housed during this quarantine period. So I think you bring up a really good point, especially when thinking about equity, that, we've got a little bit of an advantage in San Francisco because we have those resources to feel more confident in it. And I think you bring up, just to add, and then please, another county, feel free to chime in, or someone else. But I think you bring up a really good point, that kind of highlights for me, at least, this idea of frequency and duration of an exposure. I think that's really important. And so when we think about, at least in San Francisco, when we thought about masking, we kind of took both of that into consideration. So not only was someone potentially with someone for longer than 15 minutes unmasked, which could have been one, potential exposure, but if they were exposed multiple times, either masked or unmasked, or partially masked, partially not masked, whatever, that I think was all kind of a factor in that decision being made for San Francisco. But I'd love to hear what other counties' perspectives are.
I will continue to monitor Alex in case people are having audio problems and want to type it in, because I'm really curious as well. And I think that does kind of segue into our current goals and strategies around case and contact investigation. We've kind of had this both leadership driven and natural shift towards a focus on a quality improvement framework around our work and evaluating our work to find the highest impact efforts. So in kind of like both ways, we want to maximize the efforts of our staff with the highest impact so that we can take away some of the efforts that aren't adding as much to save time for our staff and be able to reach more of our cases and contacts. But additionally, it's because of that, that impact on people to stay home for 14 days where it's, you know, that's a huge ask. And for some, it's a much huger ask than others. So we're trying to see, you know, by, you know, linking all our contacts to our best match to the lab data coming in to see what their test results are. Are we having an impact? Are we finding new cases? Are we preventing forward transmission? And we also currently, and Alex, you can again chime in, please, if you have more information, but right now we have a 2-test strategy where we recommend that contacts get tested twice during the 14-day period. And so right now we don't have enough information to make a decision on that, but perhaps in the future we could use those 2 tests to say maybe we can actually shorten that time frame. So, you know, that's a very lofty in the future thing that we want to do, but at the same time it's the kind of way our thinking has shifted in the, you know, past month or so. And you know, I guess I should speak for myself. That's how my thinking has shifted. I feel like other people were definitely thinking about all those things before me, but I feel like my work has stabilized to a point where I can start spending more time and energy on those types of questions and analyses. But there's still a lot going on all the time. I'm sure everyone feels the same. And I think I probably went on too long, so I apologize, but I just wanted to share the link to all the data and reports that I took screen grabs of for this presentation are available here online, and much more. And then I put my contact information here in case, you know, questions come up or you'd like to chat more about anything we talked about today. Thank you all so much. I really appreciate your questions and participation. It's really nice to be with a group of people working on this together, because I know we're all connected in the Bay Area. One county's work is not done alone, so I really appreciate it.
Thank you so much, Hannah, and San Francisco. We really appreciate your presentation, and thank you everyone for the discussion. I'll make sure to get out that website and your contact information when we send out the recording in not too long. Before that, we still have a few minutes left. Does anyone have follow-up questions or anything they want to discuss with Hannah before we end the call?
I do. This is Melissa at BARHII. So we've heard requests from a lot of folks about having some regionalized sense of who's being impacted, for example, at work, what industries are being impacted, where is spread coming from, and how can we think about it as a region. And contact tracing data seems like a really rich tool for that. And so I think that you're doing some thinking with UCSF about how that might be possible, but I wanted to see if we could learn more.
Yeah, I think, Alex, do you know of any analyses in the current pipeline? I can definitely go back and ask our leadership what's already, you know, being talked about in the works and propose some ideas. I agree that it's really important to know, but I haven't heard of anything at the regional level. I've heard about, you know, looking into our data in San Francisco, but I haven't heard anything about the regional level yet.
Yeah, just to add, Hannah, I know that we've analyze in terms of cases in San Francisco, like in what, fields do they work in and things like that. But I'd love to see some, across county collaboration to really dive into that deeper, especially I think as Hannah mentioned, recognizing how interconnected we all are. And you saw even from us chatting about where we live and work that so many people in the Bay Area live and work in different counties. And so to separate hard across county lines feels like a missed opportunity. So I'd love to help think that through as well.
Okay.
Has
Yeah,
anyone, oh, sorry, can I ask a follow-up question?
Yeah.
Has anyone, any counties working in CalConnect, have you been able to do multi-county analyses based on data collected in there? In your spare time?
Sorry, you said multi-county analyses?
Yeah.
So we only have access to our own data in CalConnect, similar to CalReady. So I don't know if the state has done anything like that, but we haven't been able to do that. Although I think from the data distribution portal, if you've opted in to cross-jurisdictional data sharing, you can do that, but I know not all counties have opted in, even in the Bay Area. So that's more limited, and I've heard the data set is really huge when you export it. So I have a question. This is Jessica in Contra Costa. Just about as various local jurisdictions have ramped up the number of people doing case investigations and contact tracing work, how you've been able to ensure that everyone is trained, not necessarily like on all the concepts, because I know there is a lot of training option, like availability for conceptually how to do the interviews and calls, but more to ensure that data are being entered into our systems in a way, in the way that the specific fields are intended. For example, just like exposure and spread, like there just seems to be sometimes a lot of confusion about some of that. Like, are we sure we're getting the right data into the right fields, especially when there's so many new people? And things like, oh, someone's in the household, but when did the symptom onset date? When was the symptom onset date? And that impacts if someone, that goes in the exposure section versus if they're a contact. So just kind of trying to tease out some of that, and if people have any good resources for ensuring that brand new people to this area are able to really get the training and that to ensure data quality, because I mean, we need good data quality in order to answer questions and make changes.
I agree 100%, and especially I think about that a lot with how many changes we've made to our systems over even just like a short period of time. It's hard to even, remember what fields are active as the person doing the analysis, but I can only imagine what it's like to have that experience as a person who's entering data. And I think, again, Alex and Maddie and Chomsky can probably speak to this better, but in San Francisco for the cases, we kind of have like and for the contacts, we have like a team lead structure where we have someone reviewing the case, not every single detail and data point in the case, but really what we have identified as the most critical pieces before it's submitted for as being final. So that's kind of an upstream data check that we have. And we've also been working on developing some dashboards to look at just completeness of certain variables, which has already introduced some questions about, like crosstabs between two different variables to see if they're making sense, and kind of implementing some of those QA strategies as well after the fact, to feed back to the teams so that they can use to inform their data collection. But I would love to hear what other people are doing as well. Alex, do you want to speak to a little bit to the recordings on that Michelle has been doing on the CommCare system changes?
Yeah, and I don't think this is all that different from the releases that CalConnect does, where they have just basically a video with an overview of what are the changes and how does that impact your workflow. So we have some experts in CommCare who kind of do that on our contact tracing and case investigation side for those who can join, the weekly meeting, and then that's distributed after the fact. And in hopes, as Hannah said, that we can prevent as many data quality issues as we can from the get-go. And then, as she mentioned, there is this review process that happens both to case investigation records, but also contact monitoring records after they've been done. Retrospective, data quality checks are done. And then, as she mentioned, there's a lot of dashboards sort of in development for us to monitor that.
Any other questions? I know we are at time, but if Hannah, if you're willing to wait around for a few more minutes, we can squeeze in a few more if anyone has anything they need to ask.
This is Jessica again. So it's not a question, but just, I guess, an invitation. I'm Secretary of UCLH DME, California Conference of Local Health Data Managers and Epidemiologists, and Matt Byers on the call as the president of the organization. And I see a lot of names on this call of people who are not on our distribution list. We have monthly meetings, and we pretty much talk only about COVID right now. And we also have a groups.io site where there's discussion about COVID. So it's I guess my biased opinion is that it's a good resource for epidemiologists. So I think if anyone's interested in joining the list, you can reach out to me. I can maybe put my email in the chat, or maybe Melanie could distribute it. I don't know what the best way is, but I think we just want to make sure that people know that this resource is out there to talk about data-related topics.
I am very happy to get that information out. If you send me a quick email with the details, I'll gladly include that in our follow-up email with all the resources from this meeting. So if you just send me a note, I'll make sure to include it.
All right, thank you, Melanie.
Anyone else?
I threw the link that was on the presentation into the chat in case anybody wanted, and I'll just say thank you again for welcoming me to present here. It's been a great opportunity to hear from all of you and also to just take the moment to reflect on the last few months and put this together. So it's been great and I really appreciate it.
Thank you so much, Hannah. This was a great presentation and we really appreciate it. If there's no more questions, I guess we will end the call. Thank you everybody for attending. We will see you all next month. Our third Tuesday of the month, as usual, it'll be September 15th. So we will be polling our counties. Our new format is only an hour long, so it'll be 2:30 to 3:30 with maybe a few extra minutes for questions because of the discussion. But we hope to see you all there next month. So thank you again, Hannah, and everybody have a great day.